This lecture is about mitral regurgitation and anesthetic consideration. Mitral regurgitation is a very important topic in today's world. The number of patients with mitral regurgitation come with coronary artery disease in the geriatric age group. And in India, we have a high incidence of mitral regurgitation due to rheumatic heart disease. This was a severe stress and strain on the heart, and as a result, patients with mitral regurgitations can have a very difficult clinical course. What are the lecture objectives? The lecture objectives are understanding what is acute and chronic mitral incompetence, understanding the pathophysiology of mitral incompetence, the disease course in mitral regurgitation, whatever are the clinical features in mitral regurgitation, what should be the timing of surgical intervention to correct the valve problem, define the anesthetic goals, and know about how to manage these patients perioperatively, and discuss a bit about ischemic mitral regurgitation. How do you define mitral regurgitation? Mitral regurgitation is the incompetence of mitral valves due to leaflets, chorditendiny, or papillary muscle dysfunction, or due to dilatation of the mitral valve annulus, which leads to eccentric left ventricular hypertrophy, or it can be due to mitral valve prolapse, which is a congenital condition. Ischemic mitral regurgitation is present in half the patients presenting for coronary artery bypass graft surgery. Acute MR is generally seen post-infective endocarditis, which causes mitral valve rupture. Acute MR may also be seen after MI, and acute MR is also seen after as a iatrogenic complication after balloon mitral valvotomy. Chronic MR is very common in India, and in India it is due to post-rheumatic heart disease. Let's consider the etiology. Acute MR, as I said earlier, is caused by endocarditis. Post-MI papillary muscle rupture can be caused by trauma, or it can be caused by caudal rupture or leaflet big flail, as seen in mitral valve collapse and infective endocarditis. Chronic primary mitral regurgitation is present in case a person has myxomatous disease. It may be post-traumatic fever, post and healed endocarditis, post-mitral valve annular calcification, because of a congenital cleft or cleft mitral valve or an AV canal defect, or hypertrophic obstructive cardiomyopathy with systolic anti-motion of the mitral valve. It could be due to radiation, chronic secondary mitral regurgitation. It may be ischemic in nature because of LV remodeling, or it may be due to dilated cardiomyopathy. What are the common causes? The common causes are mitral valve collapse, which is seen in 20 to 70% of cases, ischemia in 30% of cases, rheumatic heart disease in 3 to 40% of cases, and endocarditis in 10 to 12% of cases. If you see this wide variation in rheumatic heart disease, this is because it varies from whether you are from the developed world or from the developing world. So the percentages are varying because of that. The developed world, a very low incidence of rheumatic heart disease, a higher incidence of mitral valve collapse and ischemia. Coming to the pathophysiology. There's a large volume overload on the left ventricle, and you have to remember that the regurgitant volume is directly proportional to the ventricular volume. So as the ventricle becomes bigger and bigger in size, and the regurgitant volume keeps on increasing. The magnitude of the mitral regurgitation depends on the mitral valve regurgitant orifice and also on the pressure gradient across the mitral valve. The ventricle fails due to an increase in the internal afterlobe, that is, an increase in the diameter of the ventricle. It can be understood using Laplace's law that the LV wall stress is directly proportional to the cavity pressure and inversely proportional to the wall thickness. So an increase in thickness of the with LVH normalizes the wall stress. So this is nature's way of reducing the wall stress by um, hypertrophying the muscle which is present in the LV wall. If there's a decrease in preload or a decrease in ventricular volume or a decrease in voltation and MVO2, all this lead to a decrease in the cardiac output in patients with mitral regurgitation. Left atrial pressure and pulmonary artery pressure depend on the regurgitant flow. So the more the left atrial pressure, the more the pulmonary artery pressure, that means the regurgitant flow is more. Pulmonary hypertension is common, though the rise in the LA volume shields the pulmonary vasculature, just as it does in mitral stenosis. Systolic regurgitation volume is returned to the left ventricle with each beat. So that means whatever is the filling of the left ventricle, in addition to the filling of a stroke volume, there's an extra filling because of the blood going back and flow between the left atrium and the left ventricle. As the MR progresses, the isovolemic phase in systole is lost as the regurgitation into LA prevents the rise in intraventricular pressure. And as a result of this, there's no rise in the LV afterload. Mural left ventricular hypertrophy keeps pace with the left ventricular dilatation. That is, as the dilatation takes place, the mural hypertrophy of the ventricular muscle wall also takes place. There is an increase in stroke volume with a decrease in the wall tension. And with a increase in the stroke volume, that is, the stroke volume partially goes into the LA and partially into the aorta. So this decreases the LV wall tension, and that is why there is an underestimation of the LV dysfunction. So despite the fact that the cardiac output is low, the LV ejection fraction may be normal. MVR makes LV dysfunction very apparent due to a sudden rise in the impedance with an increase in wall stress and decrease in left ventricular ejection fraction. What happens when you do a mitral valve replacement is that sudden relief of pressures on the left ventricle are impeded by a functional mitral valve which has been placed. And with this, whatever volume is lying in the in the left ventricle, it tends to cause an LV dysfunction. But there's a very high amount of volume which is there, so the LV ejection fraction is suddenly seen to fall dramatically. Mortality is very high after surgery for mitral valve replacement, and patients should ideally be operated before the left ventricular ejection fraction goes down. So trying to understand the pathophysiology by means of a flow chart, we'll try to understand it again. When there's mitral regurgitation, there's volume load on the LA and the LV, which gradually increases. This causes a rise in the LV EDP and a rise in the LA pressure, which leads to dilatation of the LA and LV to accommodate the volume load and to prevent congestion in the pulmonary capillary network. This further leads to left ventricular hypertrophy, which is eccentric in nature, that is, the LV dilates, and to decrease the wall stress. This further leads to an increase in preload of the LV hypertrophy, and a reduced or normal afterload. All these leads to a large stroke volume. So a supranormal ejection from the LV or a normal forward stroke volume. The forward stroke volume into the aorta is normal. However, the actual stroke volume of the LV is supranormal. This is a vicious cycle because as MR worsens and LV dilatation happens and annular dilatation happens, it further increases the LV incompetence, mitral valve incompetence. Because as the LV dilates, the mitral valve becomes even more and more incompetent. All this leads to contractile dysfunction, reduction in the ejection fraction, and an increase in the end systolic volume of the LV, which further is seen also as an increase in the LV end diastolic pressure and end diastolic volume, and an increase in the LA pressure. What it finally leads to is reduced forward stroke volume and a reduction in the cardiac output. And on the pulmonary side, there is pulmonary congestion and pulmonary hypertension which develop. This fall in cardiac output results in heart failure, and about 1/4 of the patients have died suddenly. There's a very important term which is used. MR begets MR. The LV enlargement results in an increase in MR from the altered ventricular geometry and annular dilatation. So as the disease progresses, the systolic LV wall stress is increased as the LV assumes a more spherical shape. Normally this LV is more like, like a um, like a structure which has got a long diameter and a short width, but here it becomes more spherical, more like a ball, and its efficiency goes down. This leads to an increase in the LVEDP, a decrease in contractility with reduced myofiber content and interstitial fibrosis. Finally, there's irreversible LV dysfunction, which leads to a decompensated stage of MR. So when you look at the pressure volume loops of the left ventricle in mitral regurgitation, this is a normal pressure volume loop. Look at the loop. So it's a supranormal stroke volume. So look at the shape. So if you see, the end diastolic volume is very high. Normally it's about 60 it's about 120 ml or so. And here the end diastolic volume increases to about 180 or whatever, depends on the severity of the disease. And look at the ejection. Ejection also, it starts very early, and this phase is also obtunded. So when there's a line diagram to show how different it is. So what happens is, this is a normal patient's normal pressure volume loop, and this is what it looks like normally with the ejection fraction of about 60%. When the pressure volume loop shifts rightward, as it happens in MR, the ejection fraction actually increases to 65%, but this is a false thing. So in case this patient undergoes a mitral valve replacement, the shape of the pressure volume loop becomes okay. But remember, the pressure volume loop works on the rightward side of the curve. And as a result, the ejection fraction, in case it was 50% before surgery, falls to 37% after surgery. It's a very severe fall after surgery. What are the clinical features? In a chronic compensated mitral regurgitation patient, it may be asymptomatic for many years. Patient may be asymptomatic for many years. Average interval from the diagnosis to the onset of symptoms is about 16 years. Patient gets symptomatic on normal exercise when mild heart failure sets in. Small shifts in intravascular volume may precipitate congestive heart failure. And features of right heart failure are present associated with patients who develop pulmonary hypertension. In acute MR, patients have orthopnea, flash pulmonary edema, and circulatory failure, and have history of acute MI, recent balloon mitral valvotomy, infective endocarditis, and uncontrolled hypertension. Drug history is very important to take. There is no persuasive data that medical therapy decreases the ventricular dilatation or delays valve surgery. So you can't say that you can put the patient on medical therapy and wait for patient to be okay and then do surgery late. In fact, it may be harmful to delay the surgery. Most of these patients are on digoxin and diuretics for congestive heart failure. They also may be on vasodilators like ACE inhibitors and nitrates, especially in patients who are got acute symptomatic MI. These patients may be on warfarin in case they got atrial fibrillation to prevent thromboembolism. On auscultation, S1 is usually absent, or it may be soft and buried in the murmur. S2 is audible with a wide physiological split in severe MR. S3 may be low pitched after A2 following a rumbling mid-diastolic murmur. And S4 may be heard in severe acute MR in failure. The murmur is a high-pitched, soft blowing, holosystolic, apical murmur, at least of the grade of 3:4 in the left lateral position during expiration. And this murmur radiates to the left axilla and the angle of the scapula. This is very typical of an MR murmur, the radiation to the left axilla or to the angle of the left scapula. The murmur is intensified by isometric exercises, but is reduced during well cell wear. In the pulmonary area, an ejection systolic murmur with a loud P2 may present because of pulmonary hypertension. The murmur intensity depends on the pressure differential again between the LV and the LA. In mitral stenosis, the pressure differential between LA and LV, here it is LV and LA because the direction of flow is opposite. The pressure difference is relatively constant during ejection, so the murmur is holosystolic. See, the pressure differential is relatively same during the entire systole, so it is a holosystolic murmur. The LA pressure increases with backflow. What are the important investigations? An ECG is an important investigation which should be done, and ECG reveals left atrial hypertrophy in most cases. So there are peaked P waves seen especially in lead 2. There is evidence of biventricular hypertrophy, which you can see in the lead V1 and in the lead V5, V6. LVH is seen in about 50% of the cases, and atrial fibrillation may also be seen in the ECG. The chest X-ray has evidence of left atrial enlargement against double density shadow here. You can see here the right atrial shadow and the left atrial shadow here. Evidence of LVH, pulmonary venous hypertension, that is pulmonary bay is very prominent. Pulmonary edema in acute MR, there may be evidence of pulmonary edema. Congestive cardiac failure signs, evidence of right ventricular hypertrophy, and in case it's also having a coexisting mitral stenosis, mitral valve calcification also may be seen. Echocardiography is perhaps the most important investigation to be done, and it is done for accurate evaluation for the presence or absence of mitral regurgitation, its severity, and to evaluate the cause of mitral regurgitation. A Doppler echo helps in quantifying the severity of regurgitation. The quantification of the LV systolic performance, that is what is commonly done, the ejection fraction, is an imperfect means of assessing contractility. So in case the patient has got MR, please do not look at the ejection fraction and say the patient has got good cardiac function. Ejection fraction in conjunction with end systolic volume is a useful measure of ventricular performance. So in addition to ejection fraction, you should always look at the end systolic volume of the patient. In case the patient is PAL for valve repair, a TE will help in assessing the feasibility and the way to do it. This is a typical TE of a patient with mitral regurgitation. So because of turbulence, see the blood is flowing from an incompetent valve into the LA, and if you see the jet, the regurgitant jet is in the mosaic form, is going right up to the wall, which signifies that this patient has got severe mitral regurgitation. Now, grading of MR based on echocardiography. The area of the mitral valve jet, mitral regurgitation jet, if less than 3, 3 centimeters square signifies a mild MR. If it is 3 to 6, it signifies a moderate MR. And if it is greater than 6 centimeters, like here, it signifies severe MR. If you look at MR jet as a percentage of the LA, if it is occupying, the MR jet is occupying 10 to 29% of the LA volume, it signifies mild disease. 30 to 39% of the volume of the LA, it signifies moderate disease. And if it occupies more than 40% of the LA volume, it signifies severe disease. Another way of estimating grading is looking at the regurgitant fraction. If the regurgitant fraction is 20 to 29% is mild, 30 to 49% is moderate, and greater than 50% regurgitation fraction means it is severe. What should be the timing of surgical intervention for mitral regurgitation? This also will tell you about whether we can take up a case for non-cardiac surgery in a patient with MR. Thing to remember is the optimal time for surgery for mitral regurgitation is as early as after detection of severe MR as possible. So in case patient goes into LV dilatation, he develops LV dysfunction and symptomatology, the patient will have a very poor outcome even after surgery. So the optimal time for surgery is before the patients start developing LV dysfunction. So that means before the patient's LV ejection fraction starts reducing. So again, a flow chart to show the same thing. In case the patient has got mitral regurgitation and has got symptoms, and you look at echocardiogram whether the valve is repairable, repair it. If the valve is not repairable, accordingly do replacement or medical therapy. Or in case the patient does not have symptoms of if patient has MR but no symptoms, then you should look at the ejection fraction. If the ejection fraction is greater than 60 and the end systolic dimension is less than 45 millimeters of mercury, it is safe to do non-cardiac surgery. But if it is the other way, it is not safe to do non-cardiac surgery. Surgical outcome is poor when severe MR and severely reduced ventricular function are both present. It is difficult to determine whether ventricular dysfunction is the cause or the consequence of mitral regurgitation. Patients in NYHA class 1 and 2 who did not undergo operation have a mortality rate of 4.1% per year compared to 34% in those in class 3 and 4. So just see the difference. NYHA 1 and 2, relatively very low mortality rate and very high mortality rate in case the symptomatology is 3 or 4. Once LV dysfunction occurs, MR has already transitioned into a stage of decompensation, and so the prognosis is not good. Low preoperative ejection fraction of less than 60% or a high end diastolic dimension greater than 40 predicts postoperative LV dysfunction and increased perioperative mortality. For non-cardiac surgery, caution must be exercised if the ejection fraction is even mildly below normal. It is important to remember that due to favorable loading conditions for myocardial performance, increased preload and decreased afterload, the normal ejection fraction in severe primary MR is higher than normal, such that once the ejection fraction is less than 60%, irreversible systolic dysfunction has already occurred and it will manifest as post-repair LV dysfunction. Anesthetic technique. The goals are to maintain higher heart rate, maintain sinus rhythm, have a higher preload, reduce the afterload. There should be no myocardial depressant drugs used. If the patient has got pulmonary hypertension, avoid hypoxia, hypercarbia, and acidosis. If pre-medication is given, it should be very low dose. Ideally, you can do away with pre-medication in this. Traditionally, high dose opioid technique with oxygen and relaxant is used. Nitrous oxide is generally avoided in mitral regurgitation because of very severe pulmonary hypertension. Today, we generally do these patients with smaller doses of opioids with vasodilating inhalation anesthetic agents like isoflurane to offset the myocardial depression while reducing the regurgitant volume. Using higher max may cause myocardial depression, so you should not go to higher max whenever MR is present. Maintaining a higher than normal heart rate to improve forward output is important, and because it also reduces the regurgitant volume. If you maintain a higher heart rate, the heart is able to eject more into the aorta and lesser into the LA, so it improves the forward cardiac output. You should maintain a judicious volume status with a mild positive balance to improve forward flow. Remember, if there is overloading of the circulation, it may precipitate heart failure. As I said earlier, avoid nitrous oxide in severe PAH. Central neuroaxial blockade. Sympathetic blockade with reduces the SVR, which may augment the forward flow out of the heart and thus reduces the regurgitant fraction. However, bradycardia associated with CNV must be corrected always. So it's a good thing. You may use an agent to increase the heart rate in case bradycardia occurs so that the forward flow is improved. Fluid overloading, however, must be avoided with central neuroaxial blockade. You should monitor these patients invasively only if the patient is symptomatic. If the patient is asymptomatic for non-cardiac, it is not indicated to have invasive monitoring. But invasive monitoring is indicated in patients who are symptomatic. And invasive monitoring, we mean arterial pressure monitoring, central venous pressure monitoring, and cardiac output monitoring also should be considered. In acute MR, you should also do pulmonary artery occlusion pressure monitoring, that is pulmonary artery wedge pressure monitoring also to determine the status of the LV filling. Post-operatively, ensure good analgesia, and normothermia to prevent rise in SVR. After non-cardiac surgery, in case of low cardiac output or failure, use inodilators. After MVR, it is a good way to manage the patients with vasodilators along with inotropes or an inodilator. If the patient has got pulmonary hypertension, there's a risk of RV failure, so you should use inodilators in such a case. Ischemic MR is very commonly seen today with patients, a lot of geriatric patients coming up for surgery. Patients with coronary artery disease and MR should be treated following the same guideline principles along with care to prevent myocardial ischemia. Care must be taken not to reduce the diastolic pressure as it reduces the myocardial perfusion. Patients also have diastolic dysfunction due to coronary artery disease, and thus fluid status has to be more carefully addressed. In case the patient with ischemic MR comes to cardiac surgery, the mortality is higher of a CABG with MVR. If the patient has got up to moderate MR only, CABG without MVR has a mortality rate of 3 to 4%, and a 5-year survival is 77%. A new competent mitral valve poses physiological insult on the heart, which is already afflicted by coronary artery disease. And as I said earlier, MVR plus CABG has a 10 times higher mortality rate. However, if the patient has got a severe MR and we have to address the MR, then we should do a mitral valve repair rather than a replacement. Thank you very much. This lecture is about anesthetic considerations in mitral regurgitation. Mitral regurgitation is a volume overload